College of Medicine, and is going to be talking about a subject that's also very important for everybody here, which is the issue of epilepsy and behavioral issues.
Thank you, Brad. Thank you. Welcome, everybody. Once again, my name is Corwin Williams. I want to welcome you as not only as a member of the staff here at PCH, but also as one of the board members for the Epilepsy Foundation of Arizona. And I want to say I'm just ecstatic, really, to see the turnout that we had. And we've been talking amongst ourselves, and this is really, I think, one of the largest turnouts we've had for one of the family conferences. And actually, this is our first pediatric-centered family conference. So obviously, there's a lot of interest. And once again, I'm just so happy that everyone's here. I hope it's been a helpful, enjoyable series of presentations for you. What I would say, and just to remind you, is this: the Epilepsy Foundation is the advocacy group for families and people who have epilepsy. So we're really here to kind of help serve you. So if there are topics of interest that you would like to hear about, don't feel we're fully addressed, please let the foundation know. If you have other questions that have come up throughout the course of this afternoon, please let the foundation know, because I think from the foundation side, we don't always know what families need. I know as a physician some of the issues that I like to address in the office, but sometimes they may not necessarily be medical issues. Like some of you are asking, well, how do you feel as a sibling about your as a sibling with a family member with epilepsy? I can't answer that question, and so meeting the Sinodis family may be very helpful. But I think in that regard, the Epilepsy Foundation can be very helpful. Okay, so reach out to us. Okay, and if you don't have our contact information, the contact information is in the back. So I also want to thank Deb Martin, who I think is somewhere in here, for also to help organize, as well as the Epilepsy Foundation. So thank you to everyone. So I'm going to talk to you guys about epilepsy and behavior. I will let you know, thank you for staying. I know it's late. I have about 60 slides, but we will be going through them very quickly. I think I'd probably be gliding over many of them because I think some of these topics have really already been touched on by some of the other speakers. But I think, as Dr. Goldberg said, repetition, repetition, repetition. This is something I deal with every day, so it kind of makes sense to me. However, if this is the first time you're hearing it, it may not. So there should be slides at some point available, and I think they're also taping this, so don't feel like you actually have to memorize everything. Like I said, I'm going to be moving fairly quickly through some of the slides. So as far as disclosure, I have nothing to disclose as far as grants or money coming from other sources, but I do need to disclose I am not a psychiatrist. I am talking about behavior. I am also talking about some learning issues, which Dr. Goldberg talked about, I think, a little bit more in depth. But as you'll kind of see, a lot of these issues do kind of go along with the epilepsy. And I think when you often come into the office, a lot of times we talk more about the seizures and less about some of these other issues that have come up. So I just really kind of want to emphasize some of that. As far as the objectives, I want to talk about some commonly used terms. I think Dr. Talwar already talked with you about seizures and epilepsy, but once again, I just want to review that concept. We're going to talk a little bit about the prevalence of behavior and learning problems in epilepsy patients. I'm also going to briefly review and show you some lists of criteria for common behavioral or psychiatric concerns. These are long lists. Don't feel like you have to memorize them. I just want you to be more aware of them. And then I'm just going to very briefly talk about some resources for behavioral concerns. Some things we already talked about, like the 504B and the IDEA. So what are my goals? So when you leave there, I hope you understand that epilepsy is really kind of a multidimensional problem. It is really not just seizures. I want you to become familiar with some of the common signs and symptoms of pediatric psychiatric disorders. As I'm going to mention, a lot of these psychiatric diagnoses have the same criteria between adult and children. Well, we all know children are not the same thing as adults. So the way they may present with some of these issues may be different than they do in adulthood, and sometimes there are some slight differences in what the diagnostic criteria are. I want you to be familiar with some of the potential learning problems. Once again, this is going to be one of the areas I think I'm going to move over fairly quickly since Dr. Goldberg addressed this issue. And once again, I want you to be aware of some of the resources that are available, even outside your physician's office. So, just briefly, seizure, from a very simple definition: physical findings or changes in behavior that occur with an episode of abnormal electrical activity in the brain. Okay? So that's a seizure. However, most of us are here because we're talking about epilepsy. And as the Epilepsy Foundation has defined in its website, if you've had more than one unprovoked seizure, so not due to a blow to the head, not due to low blood sugar, not because you've been drinking alcohol and stopped taking your alcohol, not due to an active case of meningitis, but you're healthy, you're well, and you start having seizures, we call that epilepsy. That's it. Okay? So if you've had more than one unprovoked seizure in your life, we call that epilepsy. So why is behavior relevant? Well, you know, if you look, there was a study looking at over 200 patients who had seizures, not necessarily epilepsy, but seizures. And notice this age group, about 4 to 14 years of age. About 3/4 of them had a recurrence of seizures in 2 years. Hence, they would fulfill a diagnosis of epilepsy. But that meant about 1/4 did not have a recurrence of seizures. And if you looked at 159 of their siblings, once again, pediatric siblings, the families noted the following behavioral issues. That about, look, if you, as far as behavioral problems, those who had had recurrence of seizures, those who had a diagnosis of epilepsy, had a higher rate of having reports of behavioral problems compared to those who'd only had one seizure versus the siblings who had never had a seizure. Okay? And if you broke it down into internalizing and externalizing, we'll kind of talk about that shortly, so don't get too caught up in that right now. Once again, you kind of see the same pattern. Those who had a diagnosis of epilepsy had higher reports of behavioral problems, internalizing behavioral problems, compared to those who'd only had a single seizure, compared to those siblings who had never had a seizure. If you look at externalizing problems, at least in this particular study, there were no differences, and we'll talk about it shortly. There was another study in which they looked in a little bit more structured fashion at behavior. And they had taken 100 people with epilepsy, or patients with epilepsy, PWE. Once again, we're looking at pediatric patients. So they used a structured interview. So same questions every time, things that have been validated to confirm certain diagnoses. They also looked at a checklist of certain behaviors. If they looked at mood self-reporting, so how do you feel? Do you feel happy? Do you feel sad? Do you feel down, up? So when they looked at all of this, about 1/3 of the patients with epilepsy had either affective or mood problems and or anxiety problems. About 1/5 at some point had thought about suicide. Now, none had made an attempt. And what they noted that looking at the age, their IQ, whether or not they were having problems in school, the type of seizure tended to be associated with whether or not they complained of affective symptoms or anxiety symptoms. The duration of the illness was more closely associated with thoughts of suicide. Looking at another study, this is about 500 patients with epilepsy, and these are people in Connecticut, actually, and they followed them for 9 years. The average age of the diagnosis of epilepsy was about 5 or 6 years of age, and the concluding interview was sometime around 15 years of age. So they followed these kids for a long time. They kind of broke this down into 2 groups. Those who had what was called uncomplicated epilepsy, by which they meant they had normal intelligence, so IQ greater than 80, and they did not have any structural abnormalities on their MRI, compared to the compared to the complicated patients. So either their IQ was lower than 80, or they had a structural lesion. Well, out of this group, about 1/3 of this cohort, once again we're talking about pediatric patients, had at least one psychiatric disorder. And 150 of them were internalizing. And here are just some examples of internalizing disorders, things that you don't necessarily see. So depression, anxiety, obsessive-compulsive disorder, bipolar disorder, schizophrenia. 111 had externalizing concerns, ADHD, conduct disorder, oppositional defiant disorder. About 10% of that group actually had multiple or fulfilled multiple psychiatric disorder criteria. Of those who had neurodevelopmental issues, so slow development, problems with language development, dyslexia, which we consider a learning disability, or some other type of learning disorder, an autistic spectrum disorder, about 40% had some type of neurodevelopmental disorder. And if you asked how many had multiple neurodevelopmental issues, that was about 1/3 of the group. About 60% of the group received special services. About 90% of the complicated group, about 44% of the uncomplicated group. So this is the group, last, the 44% of the group, once again, normal IQ, no abnormalities on their neuroimaging. Okay? And just lastly, I think, looking at a standardized survey. So once again, this is self-report. This is not quite the same as having someone trained and giving a standard psychiatric intake. But they looked at 7,000 adults in the United Kingdom who were self-reporting as patients with epilepsy. Once again, you start to see kind of the same numbers kind of roll out again. About 1/3 had anxiety or depressive disorder. Now compare that with a kind of an estimated prevalence of 1 in 6 in the general population. That was about the same percentage that you would see in people who had other kind of chronic illnesses like migraines or chronic headache, much higher than someone who has asthma or diabetes. Okay, so there may be something to the fact if your brain's not working well in one way, it may not be working well in other ways. All right, I think this is the last one I'm talking about as far as why it's important. 3,000 people, once again, this is a mixture of adults and children, and they compared them to 14,000 other controlled people without epilepsy. And I think what was interesting about this, if you look at the rates of psychosis, depression, anxiety in this group was significantly increased, but notice this, even before the epilepsy diagnosis was ever made, okay, as well as after. And if you look at suicidality in this group as well as suicide attempts, it was higher before and after epilepsy. Okay? So not to say that seizures don't sometimes cause behavioral change. We clearly have seen clear evidence where sometimes that can, but it may not necessarily be the only or even necessarily the root cause of that. Okay? All right. As far as learning, and I think Dr. Goldberg talked about this, I'm not going to belabor this too much. But once again, if you look at a group of children who had epilepsy, once again, we're talking about children, not looking at adults. We're just looking at children who had a first recognized seizure. Okay? Not necessarily epilepsy, but they had a first recognized seizure within 3 to 6 months they had had formal testing. About 27 to 40% had deficits on testing. Okay? And these are some of the things I think Dr. Goldberg already mentioned to you. Attention, problems with executive functioning, problems with visual spatial construction, verbal memory and processing and learning, as well as processing speed. Okay? So I hope with that we have some understanding about why it's important. And once again, I think when you come to the office, a lot of times you're focused on, my child is still having generalized convulsive seizures, my child is still collapsing, my child's turning blue with seizures. And I think rightly so, that's going to be the issue that you're really going to have to focus on when you're seeing your neurologist. But I think at other times, when that may not be as important, I think it's just important that we kind of address some of these learning and behavioral issues. Okay? So this gets us into the area of psychiatry. And like I said, I'm not a psychiatrist, but like I said, it's something that comes up a lot, so I think it's something that relevance to sometimes even bring up with your neurologist. Now, we don't necessarily address it, but we certainly can say, this is significant, you need to go see someone who specializes in behavioral health. But the bedrock of psychiatric diagnosis in this country and around the world is something called the Diagnostic and Statistical Manual. It's called the DSM. Currently, we're in the 4th edition revised. They're about to come up with a 5th edition. And what you should understand that it's a collection of professional opinion about what the criteria should be based on evidence and expert opinion. Throughout the decades, it has been revised as we've gotten more research and we've been able to kind of hone down on what this diagnosis is. Can we kind of tighten what this, inclusion criteria, exclusion criteria for this? But, I think it's very easy. You can go home, you can type in anxiety disorder, and Wikipedia will come up and show you what the DSM-4 criteria is. So it's very easy to find. But I think you have to understand this is not just a checklist of behaviors, and it really does take training and expertise to kind of recognize and to kind of take an individual person, kind of get some sense of whether or not they really meet some of these criteria. Okay? But I still think it's a nice resource to be aware of. Okay, I mentioned earlier internalizing disorders. So these are some examples of internalizing disorders, but I think one way to think about them, these are things that you don't necessarily outwardly see. So if someone's sitting here anxious, yes, we may all recognize that someone's tapping their foot 10 times a minute. That may be a sign of anxiety. But you may not always see that, and I think as you see, we look at the criteria for anxiety disorder, you don't see that as a criteria, that they're tapping their foot 10 times. The same thing for affective or mood disorder. Once again, how well do you kind of regulate yourself? I mean, obviously all of us get anxious sometimes, doesn't mean we have an anxiety disorder. All of us are sad sometimes, the loss of a loved one. I mean, that's normal behavior. That is not a disorder. Same thing for obsessive compulsive disorder and schizophrenia. But as we talk about some of these, hopefully get a kind of a sense of what some of the criteria are. I think one of the reasons why I did want to show you some of this criteria is just how you kind of see there's some overlap with some of these. So that it's not always as clean to saying, like, this is purely an anxiety disorder. Maybe it's more of a depression issue because sometimes that can be one of the criteria for it. Maybe they have both. So it's not always as easy and straightforward. When we talk about behavior, it's not always as clear-cut. And I hope you kind of get that as we kind of look at some of the criteria for these diagnoses. As far as externalizing disorders, these are things that are probably a little bit more obvious. If someone's hyperactive, running around the room, can't sit still, like they got driven by a motor, yeah, we all can recognize that as maybe hyperactivity. Same thing for conduct disorder. Someone's screaming at you, throwing things like, yeah, that's not normal behavior. And the same thing, too, for oppositional defiant disorder. When you say, go sit down, no, go sit down, please, no, that's a problem, okay? So as far as the neurodevelopmental spectrum disorders, this encompasses a large group of issues, whether it's slow development, whether it's a learning disability, intellectual disability, which we previously called mental retardation, but now we tend to use the word intellectual disability, autistic spectrum disorder, auditory processing disorder, dyslexia. Okay, so once again, I'm just going to briefly look at some of these, just once again to go through some of the criteria and some of the prevalence of these. So, looking at anxiety disorder, generally thought to be about seen in 6 to 20% of the general population, but once again, it really kind of depends on how you define anxiety disorder. Some of the consequences for someone who has an anxiety disorder include impaired social relationships and poor school performance. So, you know, if you have a 6-year-old who doesn't want to go out and play, maybe not such a big issue. You have an 18-year-old who doesn't want to go out with friends and just wants to stay at home all the time and is afraid to go out, doesn't want to go to work, that might begin to be a problem. Same thing for poor school performance. I think Dr. Goldberg mentioned about that. A lot of times, it's not just the environment you're in, but obviously environment shapes us in a lot of different ways, but also the genetics. I mean, if you've got a family full of people with anxiety, no big surprise, you might have some anxiety too. So something I often say is apples don't always fall far from the tree. So we don't just get hair color and height and intelligence from families, but a lot of times we also get their behaviors too. So, as far as a definition, or how it's defined, so it's defined as excessive anxiety and worry occurring more days than not for at least 6 months about a number of events or activities. So it's not just I'm scared of snakes, I have an anxiety disorder, that we call that a phobia. But it's multiple things. Is mom going to be home today? Like, you know, is the house locked? Is a burglar coming in? Is someone going to take me away? You know, that sort of kind of rumination about a certain topic that you get very, very worried about. Now, once again, one of the other criteria is you find it difficult to control the worry. Now, some people may be afraid of flying, but, you know, they're able to march on that plane and take off and go and do what they want to do. Well, it's probably not going to fall in the category of a disorder because they don't fulfill that criteria that they cannot control that worry. The anxiety and worry have to be associated with 3 or more of the following 6 symptoms, with some symptoms present at least more than blah, blah, blah. It gets very legalistic sometimes. But note here, as far as children are concerned, only one of these items is required. Restlessness, feeling keyed up, on edge, easily fatigued. You know, it's not an uncommon complaint. Difficulty concentrating, mind going blank. My child never seems to pay attention. Well, is this ADHD? Is this an anxiety disorder? Is this depression? You'll see these are all kind of shared criteria. Irritability. Once again, a very nonspecific symptom. Muscle tension, sleep disturbance. Okay? So just to give you a flavor of just what the anxiety disorder is like, and I think many of us have had many of these symptoms at a time, whether or not you've had all of those symptoms to fulfill the criteria for an anxiety disorder is probably a different story. And you probably also realize that you just can't walk into someone's office for 5 minutes, 10 minutes, even 30 minutes, and necessarily walk out with the answer to all this. Sometimes it may take time, and so sometimes that's why it's such a to go see a mental health professional who's experienced in taking history, who's experienced in working with children, to kind of figure out what's on your mind, what is going through your head. Do you feel this way? So, anxiety. What about a major depressive disorder? So, in those less than 13 years of age, it's thought to be around 2%. But notice as you get older, we tend to see more of it. 60% of adolescent depression will recur throughout adulthood. There is a genetic component, so that if you have a family member with it or a parent, you have a 3-fold higher risk of having depression compared to the rest of the population. If you look at long-term outcomes of people with depression, the psychosocial outcomes are poorer. Maybe not finishing school, maybe not marrying. The risk of suicide is there, as well as the risk of substance abuse. So presentation can vary by age. So I've heard sometimes families, even coming from psychiatrists, they say children don't get depressed. You know, I will leave that argument to the psychiatrist, but you may not notice the typical adult symptoms of depression when you're talking about kids. And that's why, like I said, it's important you work with specialists who have some experience in dealing with children. Younger children might demonstrate more anxiety symptoms, auditory hallucinations, temper tantrums, or other behavioral problems. Older children might have more irritability, low self-esteem, guilt. And once again, that could be a typical teenager. That's why you need an expert to kind of help you decide, is this just normal developmental behavior from a teenager, or is this a real psychiatric problem? Adolescents might have more appetite or sleep disturbances and suicide attempts. A lot of times it may not just be an isolated depression. Maybe there are others: separation anxiety, dysthymia, substance abuse. So it's defined as 5 or more of the following symptoms during the same 2-week period, representing a change from previous functioning. One of the symptoms has to be a depressed mood or loss of interest or pleasure. So depression, guess what? They need to be depressed. So a depressed mood, sad or empty, that they can report, or observation by others. Maybe they appear tearful. Once again, in children, note, the symptoms may not be the same. Maybe they're just very irritable. Markedly diminished interest or pleasure. Weight loss. You weren't planning to lose weight. And note in children, once again, another caveat, maybe it's just they're not gaining weight like they're supposed to be. Fatigue, no energy, feelings of worthlessness or inappropriate guilt, diminished ability to concentrate. Once again, you start to see how some of these things can kind of overlap with one another. Recurrent thoughts of death, maybe without a specific plan, or history of a suicide attempt, or a specific plan for committing suicide. So, problem sleeping. Not able to sleep or sleeping too much. And agitation, nearly every day. So maybe just feeling kind of on edge, not quite feeling yourself, or maybe feeling just run down and not really having a lot of energy. So a lot of times I think depression and bipolar get conflated. These are slightly different. And once again, I think the simple thing is depressed, obviously, down mood, bipolar, down mood, but also sometimes excessively elevated mood. So once again, the prevalence has been reported to be 2 to 6%. 60% of the time, it tends to come back. The patient may either experience full-blown or maybe just a little bit elevated symptoms, even through young adulthood. I think the thing to keep in mind when you make a diagnosis, or keep in mind about some of these diagnoses, is some of the prognosis that's associated with the diagnosis. This is a potentially lethal diagnosis. About 75% of them have suicidal ideation. If you look at the lifetime risk of suicide attempts, if you look at the bipolar diagnosis, about 44%. If you look at someone who only has a diagnosis of major depression, it's about 22%. If you look at the general population, it's 1%. Okay, so these are really serious issues. Adolescents, not necessarily known for their restraint and forward thinking, with bipolar may be more likely to make more attempts at suicide, more lethal attempts, and to start at a younger age. Once again, a lot of times these diagnoses don't occur in isolation. Okay, so there may be other psychiatric issues going on as well: substance abuse, conduct, anxiety. An issue that they noted, some of the experts have noted, is that children and adolescents may not show these kind of extreme down phases as well as these discrete elevated phases. Maybe it may be more of a fluctuation, up, down, up, down, up, down. Once again, the elation and grandiosity must be inappropriate to context and associated with a change in functioning. So there has to be an elevated phase where you feel like you're king of the world, I don't need to sleep, I can do anything. So once again, you may not necessarily see that set in the same way in a 10-year-old as you might see in a 30-year-old man. So a lot of times you may be familiar or seen this diagnosis of bipolar NOS. NOS just means not otherwise specified, which is just a way of saying you don't really meet criteria, but you're kind of in that ballpark. So you have to have at least one manic or hypomanic phase. It has to be a distinct period of abnormal and persistently elevated, expansive, or irritable mood lasting at least 1 week. If you've ever been hospitalized for that, then that counts in and of itself. During the period of mood disturbance, you have to have 3 of these symptoms and have to be present to a significant degree: inflated self-esteem, decreased need for sleep, more talkative than usual, maybe kind of pressure speech and talking like that with the sense of need to keep talking, flight of ideas, like you just can't just go on and go on, thoughts just don't seem to stop coming, easily distractible, increased goal-directed activity or psychomotor agitation, excessive involvement in pleasurable activity that has a high potential for painful consequences, like running bills up on your credit card, engaging in too many contacts. So, bipolar disorder. Obsessive compulsive disorder. Estimated prevalence much lower than the others, 0.25 to 1%, usually peaking in the pre-adolescent as well as young adulthood years. Once again, genetics seem to contribute to this. So maybe 12 to 25% of someone who has an obsessive compulsive disorder has another relative, a first-degree relative, so parent, sibling, child with obsessive compulsive disorder. And there have been some genetic studies that suggest that, once again, there may be a genetic component. So about half have comorbid diagnosis, so they may have another psychiatric diagnosis, ADHD, anxiety, mood or psychotic disorders. So, and they also notice, too, if you do fine neuropsychological testing, they may have some other learning issues that may not be readily apparent. So, consequences, well, once again, if you have a lot of obsessive compulsive, like I have to have like a completely clean place, I can't go out to a restaurant, that's too dirty, I can't do that, can't do that. You know, you may have problems interacting with peers or your or in other social settings. A lot of times they may have problems with work. You may not be able to keep a job or difficulty sustaining a job. So, symptoms are thought to kind of fluctuate but maybe remit over time or maybe be not quite as noticeable, but some typical or obsessions people may have. You fear a catastrophic family event. You fear they're going to get contaminated if you touch a dirty doorknob. You may get concerned about the way your body feels. You may have excessive scruples about something. Well, I can't do that. That's not right. Compulsions. We all know about the person who just can't stop washing their hands, or they have to repeat things, or they have to count, or they have to go check the house, make sure all the doors are locked 10 times every night. Obviously have to be lined up a certain way. So, as far as obsessions, they're defined as your current persistent thoughts, impulsive images. Note this, they have to be intrusive and inappropriate, okay? And they cause marked anxiety or distress. They can't just be simple worries about real-life problems. I mean, if you're worried about how you're going to pay the bills because you're out of a job, that doesn't count. I mean, that's reasonable, that's rational. The person tries to suppress them. They try, but you can't. And you recognize this is not normal. Okay? Now, we may not expect a child to recognize that as not normal, but once again, these are the criteria. And they are causing distress, and they're time-consuming, taking up more than an hour of your day, or they interfere with your normal activities. Okay? That's an obsession. What about a compulsion? So once again, these are repetitive behaviors or mental acts, like counting, that the person feels driven to perform in response to an obsession. And a lot of times people will say, like, I can suppress it for a little while, but I feel very uncomfortable. And when I do that, I can relax a little bit. They are there to prevent or reduce distress, or preventing some sort of dreaded event or situation. But once again, they are not connected in a realistic way designed to neutralize or prevent something, and they are clearly excessive. Okay? So once again, that's a lot. People train for years to learn how to make those sort of diagnoses, but I just kind of wanted to give you a sense of a flavor of kind of what that involves and some of the thought processes that mental health specialists have to kind of go through when they're trying to decide, is this ADHD, OCD, depression? It's not always easy. But that's where you as family members come in, because they're always going to ask you, so what have you noticed? So how do they behave in this situation? What is driving this? Okay, so once again, you can find a lot of this online. We're going to have copies of this, so don't feel like you need to keep up with all this. I certainly can't keep it all straight all the time. Externalizing. ADHD, oppositional defiant and oppositional defiant disorder. So ADHD, I think as we've already mentioned, one of the most common neurobehavioral disorders of childhood. 9% of school-age males, 3% of females. Many times the females tend to be more inattentive type. They're not going to exhibit the same hyperactivity. Often coexisting with other disorders that we've seen, oppositional defiant, anxiety, depression, language delays, learning disabilities. At its core, we're talking about inattention, hyperactivity, and impulsivity. Okay? And a lot of times it's broken down into inattentive type, hyperactive impulsive type, or combined type. 6 symptoms, and you may recognize this, often fails to give close attention to details or makes careless mistakes in schoolwork, work, or other activities. Difficulty sustaining attention in task or play activities. And with a caveat, these all have to be developmentally inappropriate. Okay? So we don't expect a 3-year-old to sit through an hour-long reading of, a Longfellow poem or something like that. But if they really should be able to sit through story time. Does not seem to listen when spoken to directly. Does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace. Difficulty organizing tasks and activities. Once again, this is some of the executive function that Dr. Goldberg is mentioning. Avoids, dislike, or is reluctant to engage in tasks that require sustained mental effort. Loses things easily. Often easily distracted by extraneous stimuli. Often forgetful. That's the inattention. The hyperactivity, the fidgeting, getting out of their chair, running around, climbing, difficulty playing, engaging in leisure activities quietly. It seems like they have a motor on the go all the time. Often talks excessively. Impulsivity, blurting out answers. Can't wait for their turn. I see a lot of nodding heads. Often interrupting or intruding on others. Okay? So they have to have had these symptoms present before 7 years of age according to these criteria. A lot of times you hear about adult onset ADHD. Once again, I leave that to the psychiatrist, but if you look at the DSM-4R, it says these symptoms have to be present before 7 years of age. Present in 2 or more settings. It can't just be in the classroom, whether it's classroom and church, church or home, church and school dance. It has to be more than one place that this is occurring. There must be clear evidence of impairment in function. So you can't have all these symptoms and be a straight A student and me to say you have ADHD. Okay? There has to be some evidence of impairment, whether it's social, academic, or occupational. And once again, it can't be better accounted for by some other problem. As we said, inattention certainly can go along with depression, anxiety, OCD too. So if there's a better diagnosis to fit those symptoms, that's what you have to put it. So oppositional defiant, 3 to 16% in the community studies, typically seen by preschool, but it can be distinguished from typical childhood behavior. 2-year-olds, 3-year-olds love to use the word no. They're not oppositional defiant. I mean, that's developmentally appropriate. The presence of oppositional defiant can be predictive of conduct disorder, but it also can be predictive of depression, attention, or anxiety disorders in adolescence and adulthood. So what is it? A pattern of negative, hostile, defiant behavior lasting at least 6 months, during which at least 4 of the following are present. Often loses temper, often argues with adults, actively defies or refuses to comply with adults' requests or rules, deliberately annoying people, blaming others for his or her mistakes or misbehavior, touchy, easily annoyed by others, angry, resentful, spiteful, or vindictive. Now, that was oppositional defiant. What about conduct? Prevalence rates of 2 to 16% in boys, 1 to 9% in girls. Economics may contribute to that. Genetics may contribute to it. Onset before adolescent may suggest a more severe and persistent course. In young boys may be predictor of an antisocial personality disorder. Long-term consequences include substance abuse, school dropouts, unwanted pregnancy, increased injuries, and mortality. So, what is it? It's repetitive, persistent pattern of behavior in which the basic rights of others are not recognized, okay, and are violated. And you have to have at least 3 of the symptoms going on for at least 12 months. Aggression of people and animals, bullying, threatening, intimidating, initiating physical fights, has used a weapon that caused serious physical harm, has been physically cruel to animals or people, has stolen while confronting a victim, has forced someone into unwanted activity. They've destroyed property, such as fire setting, with the intent of causing damage, have deliberately destroyed others' properties. Maybe they've broken into someone's home, building, or car. They may lie for their own personal gain, or they've stolen items of non-trivial value. Staying out at night, despite parental prohibitions beginning before age of 13, running away from home, often truant from school. Once again, it causes significant impairment in functioning. If they're older than 18, you may have to consider antisocial personality disorder. Okay, so those were the psychiatric behaviors. Once again, I just want to kind of quickly give you a sampling of some of those. I'm not going to spend a whole lot of time on cognition because it's getting late, but I will say this about intellectual disability, lifelong condition. A lot of different terms have been used for it. Developmental disorder, which is not quite the same thing as the Global Developmental Day, probably not quite the same thing for learning disability, but they're more imprecise. But here in this country, we tend to use intellectual disability. Prevalence, maybe 1 to 3% of the population, with most in the mild category. However, if you look at epilepsy, that rate can be higher to around 20 to 30%. What does it mean? Well, it means that you have significantly sub-average intellectual functioning, as well as deficits in adaptive skills. So reading, recognizing numbers, understanding the concept of time or money, social judgment, interpersonal skills, social problem solving, personal care, occupational skills, ability to negotiate the world safely. Once again, onset before age of 18. And this is just a little graphic kind of giving you some idea of the capability of someone who has mild, moderate, severe, or profound intellectual disability. So at one extreme, you have good self-help skills, maybe early to late elementary scholastic skills. As you get older, most are going to need some assistance working with a job and living independently. Now, once again, you'll get a copy of this, but just look at the profound side. Limited communication is going to remain dependent for most of their activities for their life. Okay? So just so you get some idea that it means something we say mild, moderate, severe, profound intellectual disability. Learning disability, once again, mentioned by Dr. Goldberg. Once again, lifelong condition affecting maybe 3 million children. Reading disability is the biggest one, 80%, but other specific disabilities exist in math, visual spatial processing. These children obviously are at an increased risk for poor academic performance, not completing high school, exhibiting behaviors that could lead to expulsion. Like I said, Dr. Goldberg went over that, so I'm not going to necessarily go through how that's diagnosed, but suffice to say there are psychometric tests that can help you make that determination. But what are some of the signs and symptoms of someone who may have a learning disability? It's harder for them to learn. So school is boring. I'm not interested in it. You know, one way I kind of put that is if I were to go to China and someone said, like, well, he's not really paying attention in school. It's like, well, I don't speak Chinese, so it doesn't make any sense to me. Same thing, if you're going into a classroom and the teacher's kind of like the Charlie Brown adult going, wah, 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 it's really hard to kind of find that to be very interesting and exciting and pay attention. I'm probably going to find it kind of boring because I don't understand anything going on. Class clown behavior. Once again, they don't understand what's going on, so guess what? They're going to entertain themselves. Maybe they spend more time on homework than their peers because it's just that much harder. It just takes them that much longer to force their way through it. Or maybe they get very anxious about school. They realize that it's not a successful environment for them, and so they get very anxious about going there because they know it's hard. I can't do what the other kids are doing. What about school distress? So grades are falling. They cut school or not in school. They just kind of step back like, you know what? This never works out for me, so why put myself there? Why put my ego there? Maybe they get held back because of disruptive behavior. Maybe they start bullying other people because they're not happy with what's happening in school. Or ultimately even failure. They get retained, they drop out, they get expelled. So once again, I think these are issues that were touched on by many of my other colleagues earlier, but you know, there's certainly federal laws that kind of govern what schools are obligated to provide. And the Rehabilitation Act of 1973 said the school has to provide reasonable accommodations necessary for students who have disabilities. And with the diagnosis of epilepsy, you certainly get the diagnosis of other health impairment. You may see that, OHI. If you have OHI, you know, it really should not be an argument about whether or not you could qualify for a 504B plan. And then we have the IDEA, which says that every child has a right to a free and appropriate education that meets their unique needs from 3 to 21 years of age with a qualifying disability, providing opportunities for that person for future education, employment, and independence. That's a law. So there are lots of different places I think you can go. I think, as Mark Valentino's already said, the Epilepsy Foundation kind of exists in that role. I think some of these other groups are places you can go to read a little bit more about learning disabilities and the law and how it pertains to you. Something also, Canada Child Care Center also I think has some nice things about transitioning. Some resources here, obviously in the state, I think Dr. Goldberg mentioned this. I can't say enough about the group Raising Special Kids. I suspect many of you already know about them. They are an advocacy organization here in Phoenix, created by parents who had children with special needs, for children with special needs. I refer a lot of my families there, and they have done a wonderful job. You know, sometimes just coaxing them through the process, sometimes even accompanying some parents to some of these meetings with the schools just so they aren't sitting there with an array of 10 school officials and you by yourself. Sometimes just having the advocacy like, okay, no, they can't say that, or yes, they can say that. But I think it's a great organization. So there's their website. Join their mailing list if you haven't. And once again, I think they've been an amazing organization. Many of my families can't say enough about them. The state itself also provides services. Many of you may be familiar with DDD. Once again, you have to qualify for a lot of these services. And it kind of depends on what sort of services you may actually get on them, depending on what you qualify for. The Arizona long-term care system, once again, requires eligibility in DDD. Before you can obtain All-Tex, you have to have a qualifying diagnosis such as epilepsy, but once again, they have criteria as to how you can actually qualify for that. But once again, these are some options for you. And so, like I said, find out a little bit more about them if you haven't. So just in conclusion, I told you I'd make this quick. Epilepsy is really not just about the seizure. Hopefully you kind of realize that encompasses a lot of different issues, including behavior, cognition, and psychosocial function. I think as a neurologist, you know, I don't just care about the seizures. I do care about that, but I also kind of care about the life and the quality of life that children have. They're making sure they're sleeping well, they're not having headaches, you know, that they are going to be able to finish school, that they can have employability if that's going to be an option for them, that they will be able to interact with their peers and go on and get married and have children and lead a full life. So epilepsy is all of that and more. Many of the behavioral disorders and learning disorders that I talked about have overlapping symptoms. So just because someone is saying, I get this all the time, my child's not paying attention in school, and like, do you think he has ADHD? It's like, well, I don't know. I mean, we have to talk about that a little bit more. And when it gets a little bit too complicated, it's like, you know what, I think you need to go see a mental health specialist or go see a neuropsychologist so they can do a more in-depth questionnaire, interview, testing to kind of figure out, is this a learning issue? Is this a learning disability? Is this an anxiety disorder? Is this obsessive compulsive? Is this depression? Okay? And it's not just the checking the symptoms on the list as we've seen, because a lot of these kind of share a lot of symptoms. Skill and familiarity with children is needed, okay? And I can't tell you how many times I've had families come and say, oh, they said my child is fine. And like, did they see children? Like, okay, we need to make sure you go see someone who sees children, because it's not the same. You know, I spent many years, I did a year of adult neurology before I did 3 years of child neurology. You don't have adult neurologists taking care of children. It's different. You have to know how to interact and think about children, and it's different than dealing with adults. Same thing is true on the behavioral side. These disorders may coexist. So sometimes I have families come in and say, they gave me so many different diagnoses for my child. Like, well, sometimes some people do have multiple diagnoses now. Sometimes they may be sloppy. I don't know. I'm not a psychiatrist, but, you know, it is possible. A lot of times people don't have just one psychiatric or learning issue. So untreated, these can be linked to poor psychosocial outcomes. So lower rates of school graduation, employment, marriage, shorter lifespans, increased rates of sociopathy and drug use. So I think I have to caution you, you know, if there is a concern about behavior, once again, you have to look at this from a developmental standpoint. Is this appropriate for the age or not? But if it's not, I think it's worthwhile to at least get an investigation. We're not saying your child is crazy if we say go see mental health specialists. I think it's like a checkup. I mean, I certainly have had people go and they say everything is fine. Like, okay. If the mental health people say it's fine, then and you're happy with that, then okay. But I don't want you to minimize that, because like I said, there are some other outcomes, and I will often tell parents, you know, it's a lot easier to control someone who's 8 than who's 17. And so you have your window of opportunity to kind of shape their life and what happens to them, and probably better do it early rather than later. The externalizing behaviors are easy to recognize, but doesn't mean they're more disruptive. Because they're more disruptive doesn't mean they're as disabling. Being anxious all the time, being depressed all the time can be even more disabling sometimes than some of the more obvious ones. And as I've been saying throughout the talk, all the behaviors should be reviewed from a developmental perspective. Is this appropriate for their age or not? So, early evaluation intervention likely lead to less stress for the patient as well as the family. There are many resources available, and you know, hopefully in the context of your epilepsy visit, this is at least getting evaluated to at least some degree. Okay? That was it. Any questions? Yes, ma'am. Yes. Mm-hmm. Yes. Yes.
Mark, you had a door prize thing?
Yeah.
Oh, okay, great.
Thanks for hanging around, everybody. I know it's been a full day, but we only have 2.5 more hours left of the presentation, so I hope you'll be fine. We're going to cruise right on through, no bathroom breaks. But we do have a couple of door prizes, just in case anybody needs a new door for their home. Thanks. These jokes don't get any better, by the way. The first one is a $50 gift card to Target. Tyler, Dr. Kerrigan, thank you so much for helping us put this together and hosting all the great speakers that were here today, our sponsors. Again, you know where we live? We're right down the road at St. Joe's, so you know our numbers, you know our email addresses. Dan, thank you for letting me pick on you earlier, and hope you had an enjoyable time and got as much out of it as we did. So.